There we go. All right. So I'm going to talk about an evolution of well, one of the programs that I'm involved in, and it's Hoʻōla UTelehealth. And in particular, we'll talk about the evolution of our telehealth program here at the School of Medicine that we've been doing for mental health care in the state, particularly rural parts of the state, and then what this evolution is on the second responder team pilot. So, but those who haven't been around, so what is HUT? That is our acronym, and originally it was Hawaii UTelehealth, and Hawaii UTelehealth does kind of exist for about 6 more days, and then our final grant expires on the 31st, and so we kind of we say farewell, but it's not a sad farewell because we're growing and we're changing, and so now we've become Ho'ola. And it's right now it's a partnership with the Department of Health, Alcohol and Drug Abuse Division in the School of Medicine to provide care uh, primarily via telemedicine. And we're focused right now with this part of the program on opioid use disorder. And with the opioid use disorder, we are even more narrowly focused on what we're calling second responder. And I'll talk about what second responder is in more in depth. So this is not meant to be all general population throughout the state who has opioid use disorder yet. Yet. There's more to come on this. And I say yet because we recognize that there are a lot of complexities around addiction care and polysubstance use. And we want to make sure that we're taking care of that. And so what we're doing and what we have done is since mid-February, we started a warm line, which operates 7 days a week, primarily business hours of the day, so 8 to 4 currently, 7 days a week, to be able to answer the call. And our initial work has been over on Maui and Maui County, and to provide that care. So and these are all little teasers. We'll get into it more in depth on kind of what a warm line is, why we've got this. This is just kind of setting the stage. But I do want to talk about why telemedicine and telemedicine, and what Hawaii Telehealth showed us is that telemedicine is needed throughout the state, particularly because of our unique geographic challenge as compared to a lot of the other states, in the sense that our counties are separated by island or by water, and that you can't just drive to the next county to go get the resource you need. Um, and then one of the things that is out in the lay press, and this headline is from a think tank of the Pew Charitable Trust, and it's about 5 years old now. But if states did change their policies, opioid treatment via telehealth could improve. And so there has been a push, not only in our state, but other states around the country, to increase access to opioid treatment via telehealth. But like I say, I want to acknowledge the inspiration behind the original Hawaii Telehealth, and the support that we received to create this model, this telehealth model of providing mental health care. And it couldn't have been done without Dr. Kelly Withey and the Hawaii State Rural Health Association to envision this, create it, provide that, provide that test bed. And we have seen that Hawaii UTelehealth is a necessary service and is in providing that care via telehealth is desired, needed, and is and is of use. Um, and then around opioid addiction, like that last in opioid addiction treatment, like that last slide showed, states can make a difference, and some states have already started. And one of those states was Missouri, where they're providing an addiction medicine doc was providing tele addiction care for opioid use disorder via telehealth, and that was the one of the initial, I should say, initial consultants, if you will, that the team from the Department of Health's Alcohol and Drug Abuse Division reached out to and talked to and find out how their model worked. And then continuing that, as we continue to evolve the program and we looked at and got some from the Opioid Response Network, ORN. I got in touch with the folks out of Massachusetts, and particularly the Grayson Center for Addiction Training, and worked with them. And then also part of the fact finding that DOH ADAD worked with Dr. Graham Chilius, who previously was over on Kauai, and had been doing a lot of work with prison care, jail and prison care for people with OUD treatment. And he also recommended that we look at this second responder concept and those who don't go and get treated in the ER or in the hospital. So first off, before doing this, I wanted to kind of give the framework of, can we do this legally? And that was, this has been an interesting road trying to navigate the bureaucratic and legal framework around all of this, because one of the primary medicines to treat opioid use disorder is another opioid of type buprenorphine, which is, it's a weakly binding opioid. It doesn't bind as strongly. It doesn't have the same sort of overdose risks that other drugs have. It competes against the opioid receptor, and so at certain levels it has protective effects against a fentanyl overdose, and when you get enough levels in the blood. But it's controlled. It's a controlled medicine. And so because it is a controlled medicine, the federal prescribing law around DEA rules, even though the feds don't fully control the states in this area, they do also, they have the DEA, which does. And there is something called the Ryan-Haidt Act that prohibits the prescribing of controlled medicines without an in-person visit. So, and think about it. I mean, you get all these people now selling hormones and weight loss medicines online and that sort of stuff, which is already, there's a lot of risk involved in that. I would say, as far as the doctor-patient relationship and how well are people, being evaluated and managed, as far as, potential side effects. And then you throw in a controlled medicine, surely there'd be people who would want to, take advantage of that. So anyway, out of COVID, the DEA and the Department of Health and Human Services did relax through regulatory changes the ability to prescribe medications for the treatment or all controlled medicines via telehealth and not requiring an in-person visit. And so currently we're on the fourth extension of that flexibility, and that will expire at the end of this year. And that's pretty much a blanket waiver to be able to prescribe controlled medicines. Now, state laws do also are in play. So here in the state of Hawaii, you cannot prescribe controlled medicines if you're physically outside the state. Even if you have a state license, if you're in California, so if I take a trip to California and one of my patients calls me, I can't prescribe a controlled medicine. We've come to also find out through this program that is a felony to do that, though it's usually not enforced. It's one of those things. So, tricky regulatory environment, and people could walk into things unknowingly. If that waiver does go away at the end of this year, last year, the federal government waited until December 31st of 2025 to put in the fourth waiver. So they waited till the very end, and the waiver went into place. So I'm somewhat I'm somewhat suspicious going into this year that it might not get renewed. If it doesn't get renewed, we have another set of rules that went into effect last year that do allow specifically for opioid use disorder um, to be able to prescribe buprenorphine via telehealth. Now, that can only be done for 6 months without an in-person visit. So the first waiver that I talked about is a lot more lenient than this next one. So at some point in time, we can do telehealth, but it's 6 months, then we have to do some sort of in-person visit. Um, and so that would be what we do. So it's either, we can get and this could work with our model that I'm doing. And so where, and particularly with second responder, it definitely works with that. So yeah, it'll change long-term care and treatment, but we're really about getting people into treatment when they're most in need. Um, so what is second responder? I kind of talk about most in need. Well, it's really working with emergency medical crews and emergency departments initially. So on this on so here is kind of our schematic when we're looking to launch in Maui. So we launched mid-February in Maui. And we're working with Maui EMS and the hospital over there. And so we've got two different scenarios. Somebody overdoses, and now we have a lot of Narcan, naloxone that people have, and it's readily available. It's over the counter, and a lot of people do bystander treatment with that. So if somebody overdoses, they could revive the person, even before EMS arrives. So that person now is, they've woken up, they're in what we would call precipitated withdrawal. They've been reversed from their opioid overdose. So once they're kind of alert and awake, once the EMS arrives, they have a choice. They can say, "Yeah, I want to go to the hospital," or forget about that. I am not going because last time I went, I didn't get a good experience. Blah 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 blah. All sorts of different stories people talking about, right? So this is where our program really wants to come in and work. What we'd like to have is those EMS responders. If that person decides to decline transport and against medical advice, not go to the hospital for further stabilization, that EMS crew is calling us or telling the patient to call us right then and there on the scene, saying, here's this program. You might not want to go and get treated, but here's these other folks who can treat it. That's what second responder is. So EMS was the first responder. We're now the second responder in that scene, and we will then take that patient off their hands and work to get them into get them on buprenorphine. Help now that they're acutely withdrawing from their opioids, they're feeling terrible. They want to throw up. It feels like they got the flu. And so getting them back on buprenorphine rather than, a street drug will also be helpful, to prevent them from overdosing. The other option is that one, they didn't get reversed, or they do decide to go to the hospital. Now, a lot of hospitals throughout our state, if you're medically stabilized, meaning, okay, we've reversed you, we've got no other reason from a medical standpoint to admit you, oftentimes you do not get into treatment that day. There are very few residential drug treatment beds available, and they are only on a handful of locations throughout the state. And so it is not a resource that people can easily tap into. So a lot of people get discharged from the emergency room with or without buprenorphine, and sometimes it's without. Some ER docs do not want to prescribe that. They see it's continuing an addiction. And so, people go out and they feel miserable, and then they look to reverse the miserable feelings they have by, using the substance that takes away that miserable feeling. In this case, it'd be opioids. Same thing for like alcohol withdrawal, right? I mean, if you're withdrawing from alcohol, how do you fix alcohol withdrawal? You drink more alcohol, and the withdrawal symptoms go away. So put the substance back on. So then, yeah, get plugged into us, and then with telehealth, and then part of our broader telehealth program is we do want to have broader behavioral health services. So we're hiring and actively hiring with our program. So if you folks know anyone, we're hiring licensed counselors to do individual therapy. We're hiring CSACs to do certified substance abuse counselors to do focused substance abuse treatment. I'm also hiring peer navigators, people who have lived experience and be there and have that support. And then we're also tying in with community pharmacies because we are doing this exclusively via telehealth for our providers. Working with our pharmacies and pharmacists to get them to become at a higher level of care of what we call clinical pharmacists. So they can do and as a clinical pharmacist, they can do limited diagnosing and prescribing around certain treatment areas based off of a protocol. So if somebody's coming in and they're on buprenorphine, but it's not enough, and they got to go up on their dose, or they're having difficulty sleeping, or their nausea is really bad, rather than have to call the doc up or the nurse practitioner, part of our program, they can go ahead and get treated for those particular symptoms that they're having. Also, we'll be doing assessment around other risk factors, such screening for mood disorders. How are they doing with self-harm conditions? All those things that sometimes maybe a face-to-face encounter helps to do. And so part of our clinical training for our pharmacists will also include that as well. And then concurrently with our program, or not concurrently, but eventually with our entire program, we will expand out. So we're narrowly focused right now on this subset population because we're still a relatively new program, and there's the opioid use and those who have just and of opioid use, those who have just survived an overdose. But eventually it'll become to anybody who has opioid use disorder. And then more broadly from that, it'll become really people, and then we'll start to expand out other substance uses disorders. And certainly we know that many people who use substances aren't just having an addiction alone. They oftentimes have a dual diagnosis of some sort of other mental health condition, right? And so it's making sure that we're providing the appropriate care for folks, and they're getting that treatment. And if it's in trauma-informed care, if they've got a trauma history, and making sure that we're being sensitive to that. We are expanding the program geographically, and we're starting with the second responder. So we've been on Maui, and we'll expand statewide. The way we're looking to go is after Maui, go to Hawaii County, then Kauai after that, and then on to Oahu. The timelines have slipped a little bit. We are just about to launch onto Hawaii next week, and then Kauai will be we're looking at mid-October, and then beginning of the year of the calendar year for Oahu. In that regard, you know, from it, from our emergency departments, they're used to seeing a revolving door. A lot of these patients coming in, get treated, coming out, and that's a drain on resources. It's also a drain on compassionate care. People, start to get burnt out on that from the caregiver side of things, but then also from the patient side, they're not getting well treated. It's not really taking care of the underlying problem for them. So, and this is meant to be an informal agreement. There are no formal agreements that have to be done so that we can run this statewide, and so that we're not running into like competition. Oh, you're working with Queens. We're HPH. We can't have you working with us because, we're trying to be, a little bit of like, Switzerland here as far as like, yeah, we're not tied to any one health system, and be able to work with us, right? And then from a statewide benefits, see this is really helping to improve, community and population health across the state. I'm getting at populations that, may not get all the care they need, particularly, and part of this program is really to, and we have a unique emphasis on also the justice involved people, so people who are part of the criminal justice system, and making sure that we're trying to find off ramps of that revolving door where we can get them into treatment, and so they're not recurring, back frequent flyers into the incarceration system, and as well, right? And so that makes stronger communities when we have people who are you know contributing to society, and rather than taking from society in different ways. So this is one way to be able to try to get people back as contributing members of society and the communities. So as I was mentioned, our second responder pilot is operating on Maui. Sorry about the lines on the slide when I changed some formatting here and it didn't work out so well. But like I said, we're focused on the overdose survivors, and we really want to get them. And as mental health providers, that behavior change doesn't happen just because you say, "Hey, I've got this service that I'm offering," especially with addiction care. It doesn't happen just because we say we've got this service. And so one of the reasons for focusing, in this particular population, well, one, we hypothesize that this possibly is a wake-up moment for the individuals who are experiencing the overdose, where they say, maybe I do need to make a change, and I'm willing to at this point in time. Now, that point in time is very fickle. That does not last very long. Once you get back into your old routines, that idea of like, maybe I should make a change, now that goes out the door. So we got to capture them quick. And so that's why we want to have this warm line where we don't just say, hey, here's the brochure, call these guys when you feel like it. We really want to try to get that, make that linkage as soon as possible, and get them, get that buprenorphine medicine on as soon as possible, so that, okay, they say, oh, I can feel better, and I'm not having to go out and, use on the street. Maybe I will engage in some more, therapy, and, work with the CSAC, and, start to work on some individual therapy as well, and all these other things. That's the idea. We're still working on it, right? We're still rolling this out, trying to get a business. And you can see, with our two scenarios that I've already talked about, where somebody either refuses transport or is transported after an overdose. So yeah, so how it works, so they would call what we see as a model, and we working with Maui, and as we working with Hawaii County EMS for our rollout next week is um, that to try to get the EMS folks to use the patient's cell phone. Right? They're on the scene. The patient's saying, "No, I don't want to get transported." Well, hey, let me have your cell phone, and we now have a QR code. So scan the QR code, pulls up the site, and they say, "Here, put in your email, and these guys are going to contact you." Or could also just dial the number. Here's the number. Talk to these guys. They can help you. So it's a facilitated introduction, but it's still the patient's phone, and the patient, who either gets to talk on the phone or hangs up the phone, whatever they want to do. Um, yeah, if there is no phone, then we go down to, here's the pamphlet, or the loved one. What we usually find is if the pamphlet gets left behind, it's the loved one who is calling or the friend who's calling, not the individual. And it's that person, that bystander who is like going, okay, you need some help. And then also with the EMS through ADAD, they're also leaving Narcan and test strips. So it's not necessarily our program from Ho'ōla UTelehealth doing it, but it's the EMS crews through the ADAD process. Um, So anyhow, yeah, they would get the education, the Narcan, and then with the Maui example, if they were to get into the emergency room, and prior to discharge, part of the discharge planning would be then that warm handoff as well, where the discharge planner, who's working with them, either the nurse or whoever, the social worker whoever they have, would call our intake line, ideally, while we're staffed during those hours that we're open. Um, so, um, so yeah, I mean, the program does appear to be useful. There certainly appears to be interest for it. And so we've made the program available for both Molokai and Lanai. As I mentioned, we're slated to launch over on Hilo next week. It is a slight slippage from what we had initially had anticipated to be working right now. And then once we have second responder rolled out statewide, we'll expand for all substance use disorder treatment and for EMS and emergency departments, in that second responder. So any SUD that they're dealing with, we'll look to help support them on the second responder side or for those folks. And it's really about, expanding services while having the staffing and the program growth to do that. So it becomes a balancing act for us. So here's a little bit about the program from an initial data run that we had pulled a few months ago from our colleagues over at well with yeah, a few of our colleagues. So here's some of the epidemiologic data um, uh, from and I'll be showing you some of the trend data throughout the state. So this is for city and county in Honolulu, and you can see between 2022 and then 2025, just the trends there and now, yeah, it's only 3 years. You had the between 23 and 24 relatively flat, but you see an upward spike happening for both fentanyl and all opioids. And then all opioids include other things like carfentanil, heroin, prescribed opioids as well. So that was a trend increase, and for last year, and the word is that uh, this current year is, you know, not a reversal of what we previously had seen. So we'll see if it, if it flattens out or if it continues to climb. I wouldn't say it's going to go back to that previous baseline. Um, Now this is coming out of a CDC data set, and there is a little aberration on this data. It's not. It looks like a U, and it looks like in 2019 and 2020 there were no opioid overdose deaths. But if you look on the left-hand side, the numbers are small. We're talking between the scale goes from 0 to 30. And with this data, anything under 10 in the CDC Wonder database is reported as a zero. So 2019 and 2020 probably were not actually zero deaths, but that would require going into into the county death records and pulling that rather than from that CDC database and getting the actual numbers. And we just didn't do that. So assume, so take that with a grain of salt, and that it probably doesn't dip as low as it does there. Um, and and then and then just following the Maui wildfires, and as many of you know that there were a dramatic increase in mental health needs for folks who were affected by the wildfires, those who were living in Lahaina at the time, and those who responded, or those who were just adjacent to it, also were affected. And part of that is increase in suicide as well as substance use, in particular overdose deaths as well. And then here's some of the data corresponding to that. And then statewide as well, kind of like that Honolulu County data with opioids and a trend and an increase. And it says here 136% in fentanyl between 2021 and 2024. And then this was some Maui emergency room discharge data. And once again, a little discrepancy in the data that only half of 2025 was reported when this was pooled. So it's probably not a drop because you're only looking at half of a year worth of data there. So in our initial start over on Maui has been a little slow, but it's a little slow, partly because you can see that on Maui there were 16 opioid related calls for this 2-month period that we're talking about. And then of those 8 went to the hospital. So half declined transport. So that lets us know that this whole second responder, what I take out of this data is, okay, we've got a patient population to serve and these people who are going AMA. It does happen. Okay. And it turns out that 7 refused transport and 1 got arrested. Not sure why, but that happened. But still, in both of these instances, there is a role, for out of hospital care for that individual. Of those, so there were bystander Narcan administration in 6 of those times, and 8 of the folks received from EMS, and it looks like there was some overlap between the two. and then where people were coming from, were more around Central Maui areas, um, and then kind of what we're learning is uh, behavior change, even when it comes to a new service and getting used to a new service, takes time and education. And so out of all these runs, and even though we said, hey, we're open for business and we're here to help, hey, we're here to help, only one pamphlet was given at the time. So that means we need more education to do with our providers and how do we work with the EMS crews and how do we work with the emergency departments and the various staff, because it's not you just show up to one emergency department. There's a lot of people who staff those departments, so you really gotta, it's getting the message out and getting it out consistently. Um, and so those were some of our initial findings. Um, so yeah, so we want to make sure that people are getting at least getting the pamphlets, if not getting the warm handoff. The ideal state is getting that warm handoff, that call to us. Um, and that's, that is my presentation. I stopped right about where I wanted to because I did want to leave some time for Q&A. And I want to, thank both Department of Health, Alcohol and Drug Abuse Division, particularly the Opioid Settlement Program, who allowed me to use some of their slides. And then from my team, Devin Takahashi, who I need to at least give a verbal shout out for the slides on the data that she pulled together and compiling all of the AMR pieces. And then and Jamie Pagan over at AMR over on Maui, who did the initial data pool. And we will get another set of data. She's looking to pool that in September, and that will be, the first 6 months of the program. So once August wraps, then we'll get another round of data, and we'll kind of see what the runs have been like.
And I would like to offer you some data if you want. We have a 5-year hospital set of all the hospitals in Hawaii. So if you had a diagnosis code you wanted us to look up, we could tell you by hospital admissions or outpatient treatments for hospital-based outpatient treatments, of course, for those diagnoses, whether it's overdose or overdose death or whatnot. We could pull those